So what we saw in the earlier one is the physiologically difficult airway. Okay? So this is an acronym. It is given in one of the articles, which helps you to remember the causes of physiological abnormality and how to deal with them. So this is a usual nice presentation. I'll just show that. So physiologically abnormality of the airway is divided into CRASH, crash. C stands for consumption increase, where optimizing pre-oxygenation, apneic oxygenation in the anticipated short apnea times have to be corrected. The second is the right ventricular. R stands for right ventricular failure. Patients who already have right ventricular failure, how to optimize them by pre-oxygenation, inhaled pulmonary vasodilators if they have pulmonary hypertension, and selecting the right induction agent, and the early use of vasopressors, as she rightly mentioned about milrinone, ligosmindone, all these things which improve the right ventricular contractility. And acidosis, severe metabolic acidosis, must correct the underlying issues and avoid mechanical ventilation as much as possible, and if possible minimize the apnea time. As she rightly mentioned, people with metabolic acidosis normally hyperventilate to wash out the carbon dioxide and correct the metabolic problem themselves. So in that situation, if you totally paralyze them and take over the respiration, that compensatory phenomena is lost. So even if you secure the airway by intubation in this patient, it is better to allow them to breathe spontaneously without paralyzing and controlling the ventilation totally. Or as we said, you can put them on what is called the pressure support ventilation and try to address the root cause for this acidosis and correct it. And S saturation stands for how patient can be hypoxemic. So patients who are already hypoxemic, low saturation. So just for the mnemonic, it is mentioned as saturation, which you can take it as low saturation and hypoxemia. So patients who are having a low saturation, if you try to intubate them without giving some supplemental oxygen, they are definitely bound to cause an arrest, especially in the pediatric patient. If the baby is showing a so low saturation, do not hurriedly put your scope and try to intubate. That will definitely lead to an arrest. So try to pre-oxygenate the patient by all non-invasive method. And this is where last week I asked about delayed sequence intubation. Instead of rapid sequence intubation, you take time to oxygenate the patient and then go ahead and do the intubation. This is a very, very important thing managing a patient with low saturation or hypoxemia. And patients who are hypotensive with volume loss, especially this is applicable to patients who come with polytrauma. So when they come in a pulsatory BP situation without volume resuscitation, without correcting their hypolimic hypotensive state, if you intubate them, again you are likely to result in an arrest. So all these conditions where patients are likely to go in for a cardiac arrest or a moribund situation by securing their airway, they are called physiologically difficult airways. So those cases have to be managed. Now what we are seeing here are all pathological conditions. Whereas in physiology also, pregnant patients and neonates and infants who require intubation, they also belong to the same category because they have a very low FRC. And in them also, if you in a hurry, for example, a woman with a polytrauma who is pregnant comes and she is stable with all the parameters of hemodynamic stability is there, but she is having a low saturation with some pain. In that situation, without correcting the hypoxemia, if you try to intubate, you are definitely likely to cause a bradycardia and arrest in that patient. The same situation will hold good for neonatal and pediatric babies also, pediatric cases also. So these two conditions also you can include into this category of pathological conditions where consumption is increased. So going to the details, from first one, consumption, peripheral consumption of oxygen is increased in pediatric sepsis, acute respiratory failure, thyrotoxicosis, and pregnancy. These patients may exhibit normal saturation during pre-oxygenation. However, the increased peripheral consumption may still result in rapid desaturation. That too, if you land up with an emergency difficult airway in the emergency situation, and you make multiple attempts, they are likely to desaturate faster. And anticipating a shorter apneic time, maintaining adequate oxygen delivery to compensate for the increased consumption is of paramount importance in this patient. So this is the first type of physiologically difficult airway. And any decreased oxygen delivery past the anaerobic threshold may lead to precipitous decompensation. So meticulous pre-oxygenation, improving low cardiac output and correcting anemia may preserve adequate oxygen delivery. The second category are right ventricular dysfunction failure or failure. These patients have limited ability to increase contractility and output in case of increased demand. So conditions like RV dilatation or tricuspid regurgitation occur quickly when RV afterload is increased. That is when there is a pulmonary hypertension and pulmonary pressures are very high. That is called the RV afterload. And this may be worsened by fluid administration in an attempt to increase the preload. So you must be very, very careful in loading these patients who have a established RV increased afterload. And rapid sequence interruption paralysis may lead to hypercapnia, atelectasis, hypoxemia, which all independently increase the pulmonary vascular resistance and right ventricular afterload, often to the point of cardiovascular collapse. So this is the reason patients suddenly arrest after intubation in such situation. So cardiac ultrasound can help to identify the failing RV and guide judicious fluid resuscitation. So appropriate vasoactive and inhaled pulmonary dilators are indicated in these cases. The second category is acidosis, where patient exhibiting profound metabolic acidemia, especially diabetic ketoacidosis or sepsis or major trauma, present an increased risk because of the interruption of ventilation and inability to match the necessary compensatory minute ventilation. So 60 seconds of apnea causes a drop of 0.1 in the pH, and the PaCO2 may increase by 12.5 millimeters, which can be devastating to the fragile patients. And compensatory ventilation is best left intact, so by avoiding intubation. This is the reason why don't be in a hurry. If you see an ABG with a pH of say 7 and patient drowsy and even the GCS is low, do not be in a hurry to intubate such patient. And if they require intubation, you must plan a strategy that limits or eliminates the apneic period and addresses minute ventilation requirement post intubation. That is very, very important. So you have to leave them on spontaneous or give them the so-called pressure support ventilation and maintain the increased rate and removal of carbon dioxide. The third condition is saturation. Hypoxemia is a known complication of emergency airway management and has been associated with a lot of complications. Peri-intubation cardiac arrest is very common. So pre-oxygenation and denitrogenation are essential to assure maximal safe apnea time. All of us know nowadays we talk about extended safe apnea period. So that is performed with a tight fitting mask or a flush rate of oxygen or a bag valve mask with one-way valve and with a 15 liters high flow oxygen. All these things have been told repeatedly, so all of you are aware of that. And upright positioning opens up the functional residual capacity. So normally we tend to keep the patient at, especially ICU intubations are more difficult because unlike your theater setup, sometimes the headboard may be a hindrance to you. The railings are maybe a hindrance. So more challenging is the IC intubation compared to theater intubation. So you must try to position the patient correctly, and you can use also CPAP to open up the functional respiratory capacity to recruit alveoli and improve ventilation perfusion. In refractory hypoxemia, you can plan for a awake intubation necessary, but the aerosol risk to be considered if it's a COVID patient. All of us know that during COVID, we were so worried to intubate a patient because of spreading the infection to other people surrounding standing near the patient, which is a highly contagious cause. And hypotension and volume lower is typically in patients requiring advanced airway management. The significant risk of hypotension in the peri-intubation period. So many of them are volume depleted or vasoplegic or have primary comorbid cardiomyopathy. So induction agents and transition to positive pressure can amplify the incapability of the myocardium to maintain their normal status and precipitate an arrest. So the treatment modality to be thought of in such situations are fluid resuscitation, not in right ventricular failure, but frank hypovolemia due and causing hypotension. Fluid resuscitation is the first choice. Then you go for vasopressors, inotropes, and then prior to intubation, stabilize the patient as much as possible, and you can maintain oxygenation to some extent by non-invasive methods. And the anatomically difficult airway is always a well-recognized and well-studied, but the physiologically difficult airway is equally important, but generally it is an under-recognized and under-discussed topic. So the crash mnemonic should help in assessment and management of the physiologically difficult airway, and that will stop with that. This is about lemon airway, which we discussed. So a few pictures I would like to show you is this is the expansion of the acronym lemon. So look externally, evaluate, and malleability score, obstruction, neck mobility, all these things. But how to examine that? Many people have a doubt about it. So this is the way you assess for the 3-finger breadth of mouth opening. Putting your fingers all together like this, not in this way, just like what you do when you do a tongue clean with a tongue cleaner, when you wipe the tongue, not that way you put your fingers inside fashion. You have to keep them together like this to make it a 3 centimeter opening, so that each finger is considered as 1 centimeter. So you have to keep it in this way vertically into the open mouth to assess that. Similarly, the hyomental distance and thyromental distance are all measured like this with the fingers vertically down, and this is much a closer picture of how you do the mouth opening testing and how you do the other two methods of mentohyoid and mentothyroid distance. And this is the malleability classification, all of you know. Neck movement, you have to do all these movements. One is flexion, another is extension, then the right side rotation, left side rotation, lateral rotation. So these are 6 movements or mobilities that have to be checked to find out the flexibility of the cervical spine. So the other topic that Anjali has discussed is